Okay, so thank you for joining us today to hear from industry leaders on how to leverage AI to improve provider, population, and patient experiences during COVID-19. My name is Bruna Smith. I'm on the marketing team here at H2O.ai, and I'd love to start off by welcoming our speakers. Prashant Natarajan, VP of AI and Analytics Solutions at H2O.ai, Deepak Chandra, Chief Analytics Officer at Mercy Health, Joel White, President at Horizon Government Affairs, Danielle Ciari, Clinical and Health IT Advisor at InnoNurse, and Nicholas Jewell, Professor at UC Berkeley and London School of Hygiene and Tropical Medicine. So I'd like to share that we'll have some minutes for Q&A towards the end of the panel. So please feel free to send us your questions throughout the session via the Q&A tab, not the chat tab, please. And without further ado, I'd now like to hand it over to Prashant, who will moderate the session.
Thank you, Bruna, and thanks to our panelists. Thank you for your contributions to COVID, public health, provider, life sciences, and policy. We have an all-star panel here, and our topic today is going to be COVID-19, leveraging artificial intelligence and analytics to improve human experiences, providers, populations, and patients. At H2O.ai Health, we believe that the highest calling of AI is to serve the humans of healthcare by democratizing AI. That's the reason we have brought this expert panel together, comprising of leading thought leaders from providers, public health, health policy, and nursing informatics to both provide their expertise and their ideas on not just how we have done with COVID, but more importantly, how are we going to prepare for a post-COVID world. One obvious comment which I would like to acknowledge is at H2O.ai Health, we appreciate what our clinicians, our researchers, our providers, and allied health professionals have done on a heroic basis throughout this new normal. As Sri Satish Ambati, the CEO of H2O.ai, said recently, you have put your lives on the line to save ours. Thank you. While we are more than a year into this pandemic, as a society, we have certainly done some things right. We have made some mistakes, but more importantly, we have learned a lot in the process. The focus of this panel is looking forward to applying the lessons we have learned for the future, both post-COVID recovery and beyond. With that, I would like to request each of the panelists to introduce themselves, starting with Deepak Chandra.
Thanks, Prashant. Hello, everyone. Deepak Chandra, I'm the Chief Analytics Officer at Bonsakar Mercy Health. Pleasure being with all of you, and we'll be delighted to share our experience with COVID and how we are applying the use of data and analytics to respond to this crisis on an ongoing basis, and how we look forward, what our new future is going to look like with this pandemic and other challenges that this pandemic has taught us.
Thank you, Deepesh. Danielle?
Hi, Danielle Ciari, InnoNurse.info. Really just happy to be here and have a conversation and talk about kind of where we started and where we're going and how data can really streamline the conversation. Working with nurses, doctors, IT people all over the world. Now we're physically not together. We're really using different tools on how to communicate and how we can not just survive, but how it's going to look on the other side of this pandemic. Thank you.
Joel?
Joel White, I'm the President of Horizon Government Affairs and the Executive Director of the Health Innovation Alliance, which is a multi-stakeholder advocacy group dedicated to using technology and data to make healthcare work better. In my lifetime, I've been congressional staff, and I've worked on almost 50 different laws in consulting and as a congressional staffer. Most of those around Medicare and public health. And most recently, our organizations have been working to secure a couple $2 billion in funding through CDC and other agencies to modernize the public health data infrastructure so that we have actionable, real-time, interoperable information for our public decisions, our public health efforts, and our clinical interventions that help improve care for patients. Thanks for having me today.
Thank you, Joel, for being here. Nick?
Yes, I'm Nick Jewell, the chair in biostatistics and epidemiology at the London School of Hygiene and Tropical Medicine. I'm a medical statistician and epidemiologist who spent most of my career at the University of California, Berkeley, where I started working on HIV and AIDS in 1981 at the beginning of the HIV epidemic, and have worked with infectious diseases ever since, most recently in dengue and in Ebola. And of course, for the last year, have been focusing my efforts on COVID-19, both in London, in the UK, and also in California, in the US.
Thank you, Nick. So let's start with some of the, I guess, the most obvious topic here, which is, as people who have been in the front lines of healthcare and policy, I think we all recognize that medicine, care delivery, and public health are data and analytics-driven sciences. So what have we done well in the last 15 months globally? First question. And a follow-up to that is, what could we have done better? Start with you, Nick.
Well, we have done some things well, despite some of the perceptions. I think one of the things that we did well early on, after the pandemic had arrived, was the initial public response to non-pharmaceutical interventions and social distancing. It was really quite remarkable in the United States and the United Kingdom how the curve was flattened in March of April of last year. Of course, as many people were saying at that time, that many people sprinted at that point, and we did very well, but dealing with a pandemic of this kind is a marathon, not a sprint, and we've done successively worse at those kind of interventions as each wave has appeared. I think you also asked what we haven't done well, and that's a long list in both in the UK and the US, which I know most familiarly. One of which I think we'll talk about is our inability to coordinate a data-driven response that was, as Joel so eloquently said, that was interoperable, was rapid, was accurate. To this day, most people are continuing to quote a number of cases and a number of deaths as if those were 100% accurate. They're still very inaccurate and indirect measures of what's going on. And we've been largely flying blind in trying to manage the pandemic because of the absence of high quality data, both at a national level, but also at a granular local level where policies are often implemented.
Thank you, Nick. And Joel, since Nick mentioned your eloquency, we'll go to you on the same question next.
Yeah, appreciate the question. I think it's an important one. I mean, first and foremost, we don't have to re-stress the fact that COVID-19 has presented unprecedented challenges and has, been a big shakeup of longstanding and ingrained patterns of human behavior. And in my opinion, what we've done really well is we've responded individually and collectively with creativity and innovation that has really produced an unprecedented worldwide response to a public policy challenge and a public health challenge. And so as people, as individuals, we've accepted limits on what we do in terms of going to restaurants and grocery stores and not wearing masks, not seeing our relatives, not attending funerals. we've accepted a fair amount of suffering and pain to try and break the back of this virus, first and foremost. And I think that should be celebrated. However you feel about lockdowns or school closings or other issues, we've accepted, at least in America, we've taken it upon ourselves to respond in a way that helps our fellow neighbors. And that's important. But secondly, I think the great thing that we've done is we responded to the pandemic with Operation Warp Speed and this, fostering of vaccines. And while mRNA type vaccines have been in the works for probably 2 decades, it took this instance to get those out into the marketplace, and that was kind of unprecedented to do that within 9 months, and to do it in a way where now 56 million Americans have accepted a shot in the arm for this technology. And I think we did that well. The third thing I think was we delivered care. We figured out how to deliver care to people at home via telehealth, Zoom in some cases, other types of technologies, so that disease wouldn't progress and people would perhaps not die ultimately because their hospitals were inaccessible or there was a concern about getting infected. So those are 3 areas: the vaccines, societal response and individual response, vaccines and therapies. I would just stress that those were made possible largely because we waived a lot of the rules of the road and restrictions in government programs to get those 3 changes. The 4, and just to respond very quickly on the what haven't we done well, I think we are using 1950s technology to figure out what's happening on the ground, to collect information, and we have a lot better ways to do that. So getting actionable, real-time, interoperable information in front of decision makers, be they members of Congress or Joe Biden or a public health official or a doctor or a nurse on the ground, that real-time information is absolutely critical to improve our response. And that's something that requires good data in real time. And hopefully we get to talk about that.
Thank you. Thank you, Joel. Daniel?
I think for me, I was traveling at the time, as I always had done in the past. And so I come from it from a different perspective. I was in Canada, I was in France, and then to the US. And I think there was a different level of seriousness depending on the country I was in, depending on the country, the different people I'm communicating with. I think one of the things that started off really well, I had a lot of IT people, a lot of different people contact me because nurses needed masks. And there's a lot of different type of nursing, and people kind of didn't think about nurses that visit homes, nurses that work independently, case managers. So I crowdsourced with basically using Twitter and email, getting masks out to nurses all over the US so they could continue to take care of patients. So for me, from a starting point, I think we really did well of networking, communicating, and just trying to help each other on a need basis. Again, I feel every country took it differently. No one, there isn't a straightforward plan going forward, whether I'm talking what's happening in France or Canada or Sweden. So I find the difficulty is people are trying, but it's not coordinated. When it comes to vaccines, I'll get a call, okay, vaccines are being done at a medical institution or at a public health institution. People are trying to scramble to figure out where to go. There might be an email system in one county and they'll email out to a certain age. So what I think the good is I think everyone's trying to come together to give everybody what they need. What we could do better is having kind of like a streamlined one voice for communication. So everyone kind of knows where to go to get the update information, especially for patients, as well as clinicians, so they can direct people. So that's kind of my take.
Thank you. And I think one of the key things that all of you have mentioned so far, in terms of both what worked well and what could be better, is the role of data analytics and AI in the process. Deepesh, as one of the global leaders in building these data and analytic solutions and making AI real, can you please share your perspective as well?
Happy to. I think my colleague mentioned all the great points of what our learning has been so far from multiple angles. I think when we look at it from the lens of a provider operating within this pandemic, at the front line throughout the life cycle of, when COVID really became a serious threat, the types of things that they had to mobilize in terms of figuring out the number of ICU beds that need to be put in place, the number of mobile beds that was needed to be there, what's the level of PPE equipments that they would be needing, where the surge is going to happen, in what market, in which hospitals. And it continues to be a moving target for provider health systems to figure those questions and be able to respond to those in a pretty agile way. I think the nature of question has kept on shifting in today's time. As of mid-February, we are all thinking about how we can figure out the logistics of delivering vaccine as the government and public officials work on delivering more and more vaccines. But the logistical challenges of delivering that on the last mile is still a big question for providers. I do think that there were several, if we step back from it as provider and operators, I think one thing that happened really well was the recognition of how data and AI can be an important piece in solving real problem within healthcare ecosystem. For those who could not put a finger on the value of doing this in a right way, I think they saw real examples of what benefit it could bring to the mix. And you saw a wide variety of spectrum of providers, some who were using data to their advantage, at least making some well-informed decision, versus others who were just responding to it in the moment. And I think that helped a lot of business leaders within the provider ecosystem to recognize the value of what it could bring to the table. And they're all giving a serious thought in terms of how digital and analytics and these components are going to be very important for us going forward. And they are putting serious thoughts and investment to make it work. And I think that has worked. That has been a bit of a silver lining for us as a data professional, I would say, in the provider ecosystem. And the last I would say is what has been really helpful and pretty mesmerizing in looking at it is when we always talk about operationalizing AI, it is the integration between the data scientist and data professional and the business leaders who have to drive that change management on the ground and actually have to make decisions. And it is easier said than done, as most of us would recognize. I think in the moment of crisis, it brought those two sides of the spectrum quite naturally together. And we witnessed cases where how the integration of business leaders came together, started working a lot more closely with the data professional and understanding and helping them break down the problem, converting a business problem into a data problem, and then taking the data insight and converting it into a business decision. You could see those loops closing pretty well. And people who were doing it well really saw a great advantage to it. And hopefully they all can carry forward those learning as we go further in solving COVID and beyond. To me, those two were big silver linings in this pandemic.
And if I may just play upon that, Dipesh, thank you for your perspective there. I also saw that Nick had responded to a question from the audience. And just to quickly summarize, the point that he made was, I think, very similar to what you just said now, which is analytics and AI must make the life easier for clinicians and healthcare professionals at the point of use. And so is that something that essentially, what do you think in addition to workflow, bringing business leaders, there's often the question of how do we compare the various predictive models that come out of it? How do we deal with accuracy versus explainability? How do we make it easy to consume these predictive models? Any thoughts on that, Dipesh?
I think in my mind, the answer is very simple, is the explainability part. I think it comes down to, we often over-index on the complexity of the model and the robustness of the model, and what kind of best algorithm are we applying to it. What we begin to lose in that process is how do we translate what the model is actually trying to do. And it makes, as a business leader who might not understand the technical details of the things, it just makes things quite difficult for them to make large strategic choices based upon something that you just don't understand. It is like, going back and making any kind of investment choice on your money into a financial instrument that you just don't understand. It's like investing in Bitcoin 20 years ago. You just don't understand it better. How can you invest, $1 million into it? And probably if you did, you would be super rich by now. But the part of explaining and being integrated with the business team through and through, and helping them be a core developer in the process of whatever you're building, is the secret sauce, and it's very hard to achieve. And I think that often becomes a missing link in driving adoption and confidence in whatever data is trying to deliver.
Thank you, Dipesh. I'd like to take
Yes, can I just make a quick comment, Prashant, that one of the things I think that's relevant to that discussion of complexity and explainability is for AI systems to recognize quickly information that really is not useful, as well as information that is useful, because there's a temptation to try and think that every source of data will provide insight into the question that you have of interest. But I have found in the past year that, for example, in trying to predict COVID hospitalization so that healthcare professionals can prepare, a month out for what the demand might be, there's this great sense in which that you could sort of move back and predict using telemedicine calls for people calling into the system to ask about symptoms. And we found that that is not really that helpful, that a very substantial number of people with COVID-19 are only first detected in a system when they show up to be tested or to be hospitalized, and don't show up downstream. So part of the challenge for AI is actually sifting what's useful and what is not useful, so that it doesn't become this huge black box.
That, I think, is an excellent point, Nick, and I'm glad you jumped in, because well before we started looking at testing and before it became completely accessible, and as an epidemiologist and a public health professional, I think you will also appreciate the fact that looking at our sewage systems provided early indicators of where the spread was happening. And it was a better indicator than the testing that was happening, given that we were a bit behind. And looking at that data, for example, sanitation data, and applying AI on that may have given us better results than some of the other things. Is that what you're also referring to when you're talking about using AI to also determine what data is used and what data is not used?
Yes, I think I think we have to think outside the box sometimes. And there's a great temptation to collect data for its own sake, when in fact, there's a cost to collecting data and trying to massage data into a usable form. And so part of the early challenge is recognizing what really is needed and what isn't.
Thank you, Nick. And in fact, this can take this to a different perspective, related, but a different perspective.
Prashant, can I jump in on that?
Yes, please. I was just about to direct that to you. Yep.
Oh, well, go ahead.
Exactly. No, go ahead. Go ahead, please.
Oh, so just to piggyback on what the example you just said, and is that, so that data that you were talking about was probably better than some of the surveillance data that we were getting reported in by hospitals, right? Some of the surveillance data was being reported in via Excel spreadsheet not real time, not in a way that was kind of usable. There was a reason why Dr. Birx in the US was getting reports and waking up at 2 o'clock in the morning to review spreadsheets because, by 5 or 6 o'clock at night, the hospitals were submitting their spreadsheets. There's an intern or some data analyst at the White House who was kind of aggregating and pulling that stuff together for a report to Dr. Birx for her to review in advance of the next day's activities. But we were probably getting, in some cases, better data about where a spread might hit in the future that would impact hospital capacity, and therefore our response through some of the methods that you talked about. And the fact that we're not using that means that our public health and our policy response is being hobbled because we're not using these modern technologies or data collection techniques. And that means, in many cases, we have a sicker population, we have more people going to the hospital, we're spending more money, more people are dying because we're not taking advantage of this types of data. So it has a very real practical impact because we've needlessly limited our line of sight into what's actually happening on the ground.
Thank you, Joel. Anybody else care to comment on that? Because I think we are hitting like several perspectives here. Deepesh or Daniel? Okay. So I think the other related question over here is two questions which I think are very important and I think are actually connected at the hip in several ways. I think the role of governments and health agencies, Joel, to your point, is more important than ever before. And if people didn't realize that 15 months ago, they do realize it today. So what kind of insights do policymakers need from data and analytics, not just in this COVID world, but also managing things such as travel passports and also preparing not just for the next pandemic, but also for the needs of chronic acute care, prevention, and wellness?
Well, let me
the five that come to my mind.
Go ahead.
Oh. I've got so logistics clearly, in terms of, I think Deepesh talked about everyone's mind right now is on the vaccine. The logistics of just handling something on this scale are mind-boggling. So data around logistics and operations, supply, I think, are critical. One of the areas that I think we're not focused on is demand. And where are consumers with respect to the vaccine? We don't have a good demand signal in the data collection infrastructure, and that's something that's going to be very important for health passports and being able to get people reintegrated into normal activities. And then I would say surveillance data in particular. I think that the challenge with a lot of these 5 areas is that we have multiple sources of truth. I think if you asked everyone on this panel where they get their latest case rate information or vaccination information or whatever, they might say Johns Hopkins or the New York Times or the COVID tracking project or whatever, but very few people would immediately say, I go to the CDC website first for all of this data. So we need a centralized source of truth about what we're talking about. If we can all get on the same page, then I think we could have maybe a better informed dialogue with policymakers, and they could have a better response in terms of what are we spending the money on? What does the data tell us we really need to fill the gaps in?
Yeah, if I could just step back from what Joel said, Prashant, and add that the very core response to a pandemic is the need to understand where infections are happening and who they're happening to and why they are happening. And of course, in the world in large, and in the US in particular, we were really hobbled early on by the testing fiasco and the inability to get testing kits out there to assess what was going on in a surveillance sense in the in the population. And part of that was, again, comes back to the logistics that Joel has mentioned. In the United States, at this point, we're 1 year into the pandemic, there is still no information at a national level on the seroprevalence for the virus. In other words, what fraction of the population has already been infected. That is only known in a few small places. Only one state, to the best of my knowledge, and I'm happy to be corrected, has done this systematically, and that's Indiana. California, where I am at the moment, does not done a seroprevalence survey. And I want to point out that we know a hell of a lot about technology and being able to survey populations and surveillance. In the 1918-19 epidemic, the US Public Health Service conducted a survey household door to door of 150,000 Americans on the morbidity and mortality associated with the flu epidemic at that time. And we haven't even come close to matching that, despite all of the technology and tools that we have. And I think there's a real question at the core of what we're discussing today is why the hell not? Why do we not know where infections are occurring now and how they're occurring? To be honest, on the vaccine, and in addition to the logistics, we don't yet know who's getting the vaccine nationally. We know the total number, but we don't know the kinds of people are accessing it, if we're getting it to the right places. And that's a challenge that I think we need to address as we think ahead to the next pandemic.
Thank you, Nick. It actually provides a great segue to a question for you, Danielle, because of the fact that being a nurse and being a clinician and on the front lines of care. One of the things that we have noticed to Nick's point and Joel's and Deepesh's, in addition to the demand sensing as well as logistics, and to the point that Nick just made, we still seem to be having a significant difference from a social determinants of health perspective. And marginalized populations that have historically not had access to care or have not been able to afford care, we still see that during even vaccination, for example, that there's enough studies out there that supports this, minority populations are still falling in between the cracks. And what are your thoughts on that? How can we use analytics to be able to identify these marginalized populations? And should we be looking at augmenting existing data with social determinants of health to make sure that the populations that have suffered the most from this pandemic don't continue to suffer?
Correct. I did quite a bit of research, and the three places that come to mind that keep popping in my head is the state of Texas, the state of Illinois, and the UK. And they have been running the data. They recognize in a lot of minority communities where the infection rate is higher. So for example, Texas tried to address it by sending vaccines to the areas where the infection was higher. And there were complaints. People wanted a different type of distribution. In Illinois, they were distributing the vaccine in areas where it was a small amount of population were affected. So people are questioning, Illinois and Chicago, why specifically in Chicago are they not sending the vaccines to minority communities where it's hit the hardest? And then as I continue to do my research, so they know where people are infected, they know where the vaccines need to go, but from the start to the finish, that in between conversation, it's not getting to the population. And the UK, from my research, and Nick can chime in if I'm wrong or right, that they've tried to distribute, and they're requesting Caribbean neighborhoods in the UK and people are kind of not sure how to distribute equitably. So this is what I've been finding quite a bit is a conversation of when the population of the hardest, even I think in LA County, they tried to distribute into the hardest hit communities. Not all of the vaccine was being able to give out. So people came from outlying communities, young, healthy people requesting the vaccine. So in my mind, when I have these conversations, it just comes back to me, whether it's in the US or not, the people that actually need the vaccine, they're getting hit the hardest versus availability. There's a gap in that connection.
And Daniel, is it fair to say then the role of analytics and AI is also being able to manage structured data and unstructured data? To your point about creating population or subpopulation specific education, alleviating the
Correct.
concerns and so on and so forth?
Correct. And when I've worked with people that are doing the actual rollouts and talked to the people that are doing the logistics, that are doing the rollouts, the nurses that are actually giving the patients that are going out there, the rollouts are going well. They're organized. I think we're doing a beautiful job, whether it's by a hospital or by a county or by a city. But I think there's just an overall disconnect, and people are using the data, and the data is there. They're using predictive analytics for who needs the vaccine. Say, for example, they decided in the Clark County that they would start with 70 and older. So they decided to go with the older population versus going with maybe neighborhoods that were hit the hardest. So to me, it's really, when I did my research to different countries, different counties, data is being used, but on the end, how the data is being used, how it's being allocated, is not, I don't find it to be equally the same.
That's a very, very important perspective. So I do want to come to something that is certainly, I think, topical on everyone's mind, including mine, which is we are seeing a slew of mutants that are happening right now, right? And we are seeing this across the globe with several mutants that are coming up as a result of multiple mutations that are still being studied and being understood. I will start with you, Nick, from a scientific perspective and statistics perspective. How should we be looking at the use of data analytics and AI from the drug repurposing, for example, or new discovery? And then go to you, Deepesh, on from a care perspective, how do we start thinking about these mutants?
Yeah, so what people aren't aware of, there are already an enormous number of variants of the original sequenced virus. It's not that there are a handful that you hear about in the news. There are literally hundreds of variants that have been detected. Very, very few of them, because each mutation essentially produces a new potential variant. Most of those, since the mutations are essentially random, don't lead to any consequences, and so that particular variant doesn't dominate in the way that the ones that we've heard of, the UK and the Brazilian and South African strains. So I answered a question on the chat that it's actually quite hard to predict. I'm not an expert in this, but I think it would be very hard to predict, what will be the next strain? Will there be a country, a particular, I won't name a country because I don't want to pick on anyone, but will there be another strain from some other country that will suddenly take over and dominate? I think that my sense is that's probably extremely hard to predict. So again, it comes back to the issue I raised early. You have to be very active in surveillance of the strains. The United States has had an abysmal record on testing and sequencing positive samples to detect strains. We're only just getting into that act now, as compared to the United Kingdom, where from the early part of the summer, at least, if not earlier, they were testing 10% of their positive samples to detect strains. And that's part of the reason they detected that B117 strain so quickly. And so that comes back to surveillance and having an automated system. And AI, I think, likely could be very helpful in determining the best way to sequence samples in a way that would be most effective in detecting not only the existence of new strains, but which strains are likely to be more transmissible or have an impact or dominate in the evolutionary landscape. So I think that's where it is, but I'm not an expert on it. I will say also that it's very hard to predict the impact of specific mutations as to how they'll play out in the field, as how the virus is transmitted from person to person. I must say it was a great shock to me that the B117 variant is associated with a substantially higher rate of mortality than the original strain. That's not normally what happens. So I suspect that's an indication that it's a little hard to predict. And that means we have to be active on the ground. And again, the only way to know that is to have effective data collection systems that allow you to detect increased transmissibility and increased morbidity, or less for that matter, as it's happening, rather than, after the horse has left the stable.
Thank you. Thank you, Nick. Dipesh, I think Nick has kind of explained that really well. So I'm going to take the chance to actually ask you a slightly different question, right? One of the things we have seen as a result of COVID-19, and we will get past it, right? We will get past it, and we will be in a place where COVID-19 is not going to be the threat that is anymore, or we will learn to live with it, frankly, in several ways. What do you see in terms of what health systems are dealing with respect to chronic disease management, wellness? So there is enough data to show that people with, for example, cardiac conditions are not going into hospitals. People are not going in for cancer treatment. People are not going in for a lot of things that they should be going in for because of the fear. What does this mean for providers, Dipesh?
No, this has taught us many things. I think both operationally, financially, and clinically, the health systems have come together to unique set of problems. And let me maybe give a few examples there. I think clinically, one of the biggest challenge for us has been deferred care. Especially with chronic illnesses, or even with some elective surgeries and such, and the further you delay them and defer them, it just presents a different level of comorbidity risk and fatality and such that comes into the picture. So as a provider, as we are helping the volumes to come back and reschedule patients for their surgeries and such, and the more deferred care is happening, it is presenting unique set of challenges as to who we need to prioritize, either with a limited capacity or limited staff or limited equipment and limited PPEs. If you have to choose, between 10 patients to call the first two, should I use data analytics to do that prioritization, and what that could look like? And those are, important consideration from a chronic disease management perspective, because we are going to see that cascading impact of this pandemic, and the variants are going to reset some of our normalcy. We will, come back, scale back, again, reopen, come back, scale back, reopen, and it's going to come through a few cycles. So this is not the last of what we are going to see. So as a provider system, we just need to be ready as, more and more deferred care happens. How can we manage patients better, prioritize them with the volume that we can afford? I think it presents a different set of challenges also from the financial sustainability of the health systems. Given a lot of it is still very volume driven business, and as electives are taken out, as some of these other surgeries are taken out, especially with the acute health systems, the challenge is it presents it as a very unique cash flow challenge for the health system to sustain. And the government is supporting the health system through several levels of stimulus, but they are going to begin to wane out very quickly this year and next year. So it presents again a different set of challenge, that what are the different ways in which the hospital's revenue stream can remain stable by the expansion into things where we can deliver care outside the four walls of the hospital. We can use virtual care a bit more. We can use home health a bit more. And how can we, maintain that financial angle that is very important for providers who are already on a very razor thin margins. And I think the last aspect is just from an operations perspective. I think there was a question in the chat that was just around variants, and Nick touched upon that. I think the nature of pandemic is going to present a lot of unknowns for us, which would mean that we might have to do this all over again, not with the same level of magnitude, hopefully with a diminished level of magnitude, but these unknowns are going to present unique set of challenges for us as providers operationally. So the nature of the question is pretty much changing for providers from a quarter to quarter basis. And last quarter, we were worried about, providing again more ICUs and how the vaccine and other things are going to come. This quarter, we are much more focused on scheduling and prioritizing patients and such. And next quarter, we might be something else. So the nature of problem is just evolving so fast that operational readiness to use data, to make those decisions, to react to those situations with much degree of agility is going to be an ongoing challenge for us for a foreseeable future.
Thank you. Thank you, Deepesh. And one thing I must say is I have done a lot of these panels over the years, as panelists know. I have not seen as engaged a panel where the panelists are actually answering questions in chat in real time. Deepesh just mentioned that. Nick, Joel, Daniel have all been answering. So thank you so much for making this, I think, one of the most interactive panels, frankly, I've been on. We should have you back for more of these down the line. Joel, I'd like to touch upon something from your perspective, right? You are, as the country's leading expert on health policy and bringing these analytics insights to life to Congress and the White House and others. The point that Deepesh made about what health systems are dealing with, is it fair to say that Congress has a slightly different problem, where there's a lot of money that's being spent, but with not as much clarity from a data and analytics perspective on what it should be spent on?
I think that's right. I think what I've seen over the years, and again, I spent 12 years as congressional staff on Capitol Hill, is that a lot of times when members of Congress don't know how to solve a problem, they will throw money at it, because throwing money at it is a solution, right? And what we've seen increasingly over time is that Congress has been deferring to the executive branch some of the thornier solutions to very technical challenges. So, modernization effort. But there were no parameters around what that looked like, largely because Congress in 2006 had already enacted a law, the Pandemic All Hazard Response Act, that said CDC really needs to stand up a near real-time, nationwide, interoperable public health data surveillance network. And if you talk to CDC, what they'll tell you is they have 100 different surveillance networks, and they'd like to consolidate those down into just a couple. And that's important, but that takes money, it takes leadership, it takes a plan and strategic execution. And right now we're in the middle of a transition between administrations. And so some of that's been delayed a little bit, but there's been a lot of money thrown at this data challenge over the last year plus. And that's good because I think we've underfunded investments in public health data infrastructure. But now the real challenge is with all this money, and it's probably about $3 billion and it may grow to more. What do we do with that? How do we spend it effectively? Because not everything is a money challenge. Some of this is, there's 4 primary public policy areas I think we need to reform to get to an effective nationwide surveillance network, but and some of those don't involve money. So having a plan and executing on it is probably the next big step. It's not necessarily a money step.
So I think we started this conversation talking about the humans of healthcare, clinicians, researchers, allied health professionals, and I think most importantly, patients and populations. So I would like to kind of maybe before we go to other audience questions that have not been answered, Danielle, what are some of the lessons that the nursing community, the clinician community have gotten out of this, and how can we use analytics and AI to manage things such as burnout and attrition, which are all too real?
So much has happened. It's felt like it's been a big wave over everyone, and everyone keeps trying to shift gears to the next kind of crisis situation. So when it comes to burnout, I see a twofold. I see existing clinicians being drafted to COVID units or volunteering to go. And you don't know how long you're going to be there. You don't know how long the cycle, trying to figure ways of rotating people out. I've talked to several ICU and surgical teams across where basically surgical suites maybe off and on have closed, and re-educating those existing nurses. Maybe it's been 5-10 years since they've worked in an ICU. And so working on that change management and that anxiety of, okay, do I feel qualified? Do I feel prepared to go back and to do ICU? When I've been in surgery, I've talked to several nurses and doctors that may have been working at universities that have volunteered and come back into hospitals to help managing, how do you do the education, changing from face-to-face to virtual has been a big thing, completely all the way around the world, using the data to go, okay, who's going to be the most successful at this? And it's a big cost to re-educate people from going from surgery to ICU, or going from academia back to the floor to help, or even just running, giving injections, people coming out of retirement. I've talked to several people that have retired and they're coming back to help. So I feel the will is there. I feel people are really focused on the virtual education and everyone's trying to contribute. When I look at other countries, they're focusing on virtual education to help with the burnout. And on the other side, say like a Finland's taking their existing digital health and using data analytics to help patients self-triage. So when they come into the clinics, they have that data, they know what the people's symptoms are, and then they can kind of gauge, should I come and should I not, using a chat bot, using the data. So people are self-educating, they're putting themselves out there, and they're trying to do their best for their society and their community by saying, hey, I think I might have these symptoms. Okay, let me try this logarithm to see if this is true. So half the time to prevent burnout is rotating the people that have volunteered to help, rotating in the people that have not been in those environments for quite some time. And then, patient education, where telehealth was like, nice to have, and people are pushing it. Now it's like, oh, I really want it. I want to do it. So whether it's educating the patient, whether it's educating clinicians, I really feel people have tried to come together and use new tools and been welcoming of new tools, because we're all in it together.
Thank you, Danielle. And again, the one thing I would certainly like to point out in terms of wrapping up this conversation is your point about education and learning. And we at H2O have been bringing the best of data and data science together in terms of the Kaggle grandmasters who are working on many of these issues, both from a provider perspective. How do you do risk stratification, patient self-reported symptoms, from a pharma perspective in terms of drug discovery and repurposing, from a public health perspective, as we are working with Joel and Nick over here. And I think that's the most important thing, right? It's how do we create a community, because the pandemic doesn't care about anything else really, and it affects all of us. And how do we bring these perspectives, as you all have so beautifully brought to bear? Now, the challenge with kind of a panel like this is an hour is never quite enough, given the knowledge and the expertise each of you brings. I think if we polled our audience, they would love for this to continue, but unfortunately, we do have a stop at 1 o'clock. And like I said, we would love to have you back, follow up. I know that you have been responding to questions, the four of you, on the chat. Bruna, do we have any open questions that have not been responded to?
No, we don't.
Okay.
All the questions were answered.
Excellent. So like I said, I've never seen anything like this before. Thank you, panelists. So maybe let's use the remaining 2 minutes to kind of look at the future, right? So just go around the room, starting with you, Joel, and Danielle, Deepesh, Nick. Where do we go from here? And how do we apply these lessons to create the next generation data analytics and AI solutions that will allow us to do a much better job than we have done?
So I think you called on me first. I think we've invested in the infrastructure. We got $3 billion. Now we need to invest in the partnerships. That includes technology companies. It includes the people involved in the data at the public health offices and the clinical offices. I think we need to do 4 things. Well, first, we need to have a plan, right? And we're working on that. The Biden administration has just come in. They've only been there a month, remember? And so they're figuring out how to do this well. But we need to identify and prioritize the data. We need to standardize and normalize it so that we're all collecting the same thing across all the different settings. We need to then automate the reporting to reduce burden on clinicians. Let's get rid of the fax machine. Let's get rid of the spreadsheets. And then the 4th thing is we need really an ability to access that data, whether that's through hybrid cloud, centralized hub model, or some other type of structure. We really need to be able to get access across the 3 different types of providers: public policy, public health, and clinician, and make those two-way streets. That way we'll maximize the response. And that way, I think, any future pandemic we can address in a much more informed, better way.
I think it's myself, Danielle, next. Really something that keeps playing back in my head is public health. There's a disconnect of what public health is doing, and maybe it's clinician at a hospital or clinician at the company. You don't have that direct connect. You don't have that reach. I have a better connection with public health officials in other countries because of how they structure their healthcare system. So I agree, there's not a two-way conversation. There's not one place to report. Each place is reporting within their silo. It's not like, oh, I have these lists. These are the patients that are positive. This is the treatment. This is where this bank of information is going that everybody can share and everyone can pull from. So that, to me, that screams right there that there are tools that exist, but bridging that connection from what's actually happening and then funneling that data so it goes broad and everyone can kind of see the big picture. It's still like a silo system in the communication and the information, which unfortunately it affects everyone. You know, it affects you, me, everyone. So to me, I always come back to how we communicate together and share information, and how we basically share our tools together. So going forward, I'm always looking and researching, you know, what works, what doesn't work, what's worked in the past. And even in my research, I found, say, in the Middle East, they had a protocol for mirrors and they just expanded on that. Or Finland took their existing digital health and expanded on that. In America, we didn't have an existing anything to grab to or to expand on. Like Joel said, you know, we're still developing the plan, you know, after a year. We're still trying to get all the pieces of the puzzle together. Everyone's aware there's a problem, and everyone's aware that everyone's in different little sections, and everyone's trying to come to the table and have conversations like these so we can better improve the situation. So that's just kind of my personal take.
And you know, from my perspective, I would say something simple. Given we are at the backdrop of H2O here, I think for technology companies, their ability to help connect the dot is going to be very important. Often to problems like these, it comes out a bit left field that we have a solution and somehow it connects to your problem. I think the work needs to be done a little bit more in terms of translating how the problem connects to the solution that a lot of great minds are putting together from a tech industry perspective. So while we can talk all day about the problems, and you know, the tech players can talk all day about solutions that they think will solve the world's problem, I think there is something left in between that we just need to figure out how to connect those dots. So I can give you more examples around those, but I think our future is going to be much data enabled and analytics enabled if we do a much better job at connecting those dots.
And last but not the least, Nick.
Well, I don't have too much to add, and I see our time is up. And I don't want to end on a negative note, but I do want to point out that, picking up from some earlier comments, this is not the big one that we're going through now. This is not the pandemic that those of us in the business really lose sleep at overnight, bad as it has been. This is a virus that's not as virulent as many viruses. So there's a real threat that we're going to have to learn, not just to get through this pandemic, but how to get through the next one and the next one and the next one, because they're happening with increasing rapidity over the last 20 or 30 years. And this is certainly not going to be the last virus of this kind. So I think we have to learn how to invest in public health, which is a very untrendy thing to do when there's not a pandemic going on. We always like to invest in medicine and clinical responses rather than in prevention and preparedness. And so I think we're going to have to learn how to do that and connect technology companies with the public health system in countries which is vastly underfunded and really operating on a shoestring, and somehow make those connections so that we're far better in a far better place when the next pandemic comes.
On that note, Bruna, again, thanks to our wonderful panelists. Thanks for the highly engaged audience. Thank you for the responses in real time to each of you. And Bruna, back to you.
Yes, so I would like to thank our great speakers for the amazing panel discussion. The recording of the virtual panel will be made available on our website and YouTube channel. I hope you have a great rest of your day.
Thank you.
Bye.
Thanks, Bruna.
Thank you.